And first of all, I thank Dr. Manas and Dr. Sastry for giving me this opportunity. Um, this is uh, it is a small 28-bedded hospital having all the gadgets, in, even including the biplane cath lab. So even this is a small 28-bedded hospital having a biplane cath lab. We do all subspecialties here. Um, so the role of intraoperative neuromonitoring, basically what, when, where, why, who, how, who. So if we see, I mean, if any person uh, sees through this image, there is no problem. But if you see this image, we are seeing the like only one way is the better than the other two ways. So how we can identify this? So the problem here is the, the surgeon itself. Like surgeon does the problem. So iatrogenic injury is the major problem here. So how can this occur? Like what are the problems? So either maybe surgical problems like distraction, compression, or blunt injury, or anesthetic problems, maybe hypotension, ischemia, or temperature, or hypothermia, or cervical extension during the positioning, or direct compression, or blood supply, or all these are the problems. So what happens? So so we are creating a problem. What was the with and without? Like generally without I'll only quote the intramedullary resection. Generally with IONM it is around 5% and without is like around 23.8%. This is quoted. And so basically, we do this to improve the quality of life. I mean, surgeon is the first person, and all these are the gadgets. Whatever my previous speakers showed the anatomically how we do that, and here what I am showing is like a physiological way how to do that. So as the surgery is improving, and even for the like the medical facilities are improving, the life expectancy is also improving, but the quality of life is not if we don't use all the gadgets. So why I avoid iatrogenic injury? Just to reduce the cost first thing, and to improve the quality of the life. So how we can avoid timely detection of the changes, so that I mean even before we damage, if we identify that, that will be good. So as I said, previous my two speakers they told about the anatomically how they can do, but here I am showing the functional way. So so the functional assessment is through the intraoperative neuromonitoring, and how we do that. So both the non-provocative and the provocative tests. So commonly we use MEPs, SSEPs, and a triggered EMG, especially in the intraoperative setup. So the positive predictive value and negative predictive value are very good in this. And how effective is the IONM? This is almost good, almost good. Around 93% is effective. Um, so is it when it is appropriate, even before ongoing monitoring or time specific assessment or ongoing and monitoring during the surgery? It's almost every time it will be useful. So you can done in the preoperatively and during the intraop. And so the neurophysiologist is a must. And can we do the monitoring in less than 2 years? Yes, we can do. But most of them, they'll say that because of the myelination, there will be a problem. But even, I mean, I use like almost all these cases, especially the lumbosacral and all these, the voltage will go high. Like nearly MEPs, we will get at 300 and 350 in a regular patient, but here it is around like 600 and 670. And is it much reliable? Um, like some false positives will be there, but it is still reliable. And this is how we will place on every patient. I used to place all these 10 muscles on the one side and 10 muscles on the other side, and MEPs, SSCPs. This is my routine practice. I do for every case. Every case means like spine. I do for every case, and intraoperative like cranium depends on my choice. So, sorry. So like this, we do on the muscles, hand muscles, and then the foot. Then even in the previous, I showed the even putting it in the, in the anal sphincter and bulbocavernous reflex. So, so what is this? Like dorsal columns, we will check the SSCPs, and this is the upper limb one, and corticospinal tract. We do the MEPs basically, and so spinal cord. Uh, the blood supply is totally different. So dorsal columns doesn't give much importance, and only the MEPs are much more better than these. So this is the triggered EMG. Generally, we will put in a rotator out zero point 0.1 or zero point 0.2 to a 1, and then we will check it. And generally, if nothing is there, then we will feel very happy that nothing. I mean, we are doing safely. And SSCPs, as I said, this is the upper limb trace and this is the lower limb trace. Um, this is MEPs. So spontaneous EMG we always check, and along with that, the triggered EMG also we will check. I check for every pedicle screw. Um, and we check like around like a 30 milliamperes or so. I'll start with that, and I'll come down up to 4 to 6, and like if anything is less than 7, I feel that there is a breach, and definitely I have to remove that screw and need to place it. So you are seeing that the dorsal rami branch is doing, but in the triggered EMG, the down whatever you are seeing here, this is the triggered EMG, and it doesn't make it. Sorry. Sorry. So this is a case I want to show you, like before positioning and after positioning. Like this is the OPLL with the severe cord compression. So severe cord compression. So the TOF is one of the most important, one of the important thing for the anesthesia checkup. And then we will position the patient. I mean, first we will do on the supine position, and then we'll go on to the prone position, and once again we will check it, and based on the MEP recordings and based on those the changes, we will adjust the position. That's one of the most important thing here. And once we are done, then we will see the post positioning, everything is same. Then upper limb SCCPs and lower limb SCCPs, and this is the lateral mass screws. Even the lateral mass screws also, if anything is less than 7, you should change it. um, Here I don't have much time to show, so I'm skipping this case. The rest of the things are the same. So even transcarticular screws are this. This is the post-operative outcome. And another case is this is for the lumbar. The same. It's everything is the same. So we'll place the retractor and then we do the surgery, minimal invasive surgery, MEPs will be checked. For everything like 15 to 30 milliamperes, we will check. Here, if you see, I did the over the top decompression in these two levels, and the patient is that's so intraphysiology always, and another one is the spinal cord surgeries. Generally, spinal tumor surgeries are the most important thing. So this is the placement of the D-wave monitoring. D-wave monitoring and MEPs are concurrent. I mean, if they are both concurrent, and you will not feel anything bad. Like most of the times we will have a lot of fear, but once we do the surgery and both are present, then you can say like happily what's happening. Yeah, you can say very happily that nothing is happening there. Everything is good. And you can say even before the patient moves the limbs, you can say yes. If MEPs are gone down and D-wave is present, still the patient will recover in 3 to 6 weeks. And if MEPs are gone and D-wave is gone, um, I never had that occurrence, but in the literature they'll say remove the total tumor because already function has gone. So this is another tumor. I think my time is over. Thank you. Thank you very much.
Thank you so much, doctor. A quick comment or question from the audience. I have one quick question. Any of the previous two speakers, are they using intraop monitoring? Because the more minimal invasive and more robotic you go, do you feel the need for monitoring or no need for monitoring?
Yes, in selected cases, you should still use monitoring. There is a severe cord compression, dorsal cord compression, like one in thoracic spine, which I showed you, we did monitoring. Another, just a comment for this, I mean, we use head caps for all the operations. We found head cap was not used. So whether that is a common practice or
No,
that
no,
is
no.
what
I'm always bald.
Thank you. I think we can go on to the next speaker. Thank you.
Thank you, sir. Thank you very much.
Yeah. The next talk is going to be online. You can have the video up, please.